Yep.
Basically for them to act as a catalyst for us to think and talk about how we can best combine both primary care practice and education and transformation. Is this supposed to be going?
Yes.
Okay, thanks. Got it. Oh, got it. All right. So to start with, I want to introduce all of our panelists. So I'm going to be working here from my right to left, your left to right. So starting with Richard Gibbs, and also if you open your pamphlets, you will be able to follow along and remember who everyone is. So starting here, we have Richard Gibbs. After training in family medicine at the University of Washington, Doctors Richard and Tricia Gibbs founded the San Francisco Free Clinic. Introducing students and residents to primary care is a core part of the clinic's formal mission. The Gibbs are both professors of clinical medicine at UCSF and associate professors of clinical medicine at Yale University School of Medicine. And in the fall of 2013, the Gibbs received the Yale Jefferson Prize from Yale University for their efforts in teaching. Moving down the line, we have Hali Hammer. Dr. Hali Hammer is the Director of Primary Care for the San Francisco Health Network, the integrated delivery system of the San Francisco Department of Public Health. The San Francisco Health Network Primary Care is 14 community and hospital-based primary care health centers and associated programs serving over 70,000 patients throughout San Francisco, so no small job. Prior to this position, Dr. Hammer served as the medical director of the Family Health Center, a role that was very close to my heart, at San Francisco General Hospital. A professor of clinical family medicine in the UCSF Department of Family and Community Medicine, Dr. Hammer continues to lead seminars in continuous quality improvement for family medicine residents. Next on the line, we have Maria Patanwala. Did I pronounce it correctly? Maria Patanwala. Maria is a second-year medical student at UCSF and is a participant in the program in medical education for the urban underserved, known abbreviated as PRIME US. She has a strong interest in primary care and is committed to building partnerships between community-based service organizations and community health centers to better serve patient needs. This summer, Maria was a Bridges Curriculum Ambassador working on a quality improvement project at Maxine Hall Health Center, which is part of the San Francisco Health Network Primary Care. Next on the line is Julia Shaver. Dr. Shaver attended medical school at the University of Texas Southwestern and residency at Group Health Cooperative in Seattle, Washington. At Group Health, she was trained in the patient-centered medical home model and developed a deep interest in how family medicine doctors can think critically about healthcare delivery to make our care better, more cost-effective, and sustainable for both patients and providers. Dr. Shaver currently practices medicine and teaches students and residents at the pretty newly started Kaiser Permanente Napa-Solano Family Medicine Residency. Next on the line is Lealah Atkinson-McEvoy. Did I pronounce that right? Dr. Atkinson-McEvoy is the medical director of the Pediatric Primary Care Clinics, where she's responsible for the day-to-day operations as well as managing and measuring quality metrics and outcomes. As one of the associate residency directors, she's also responsible for the continuity clinic curriculum for residents, teaching them about panel management, care coordination, disease registry, and wellness promotion. Next down the line is Erica Monasterio. Erica Monasterio is a family nurse practitioner and a clinical professor in the School of Nursing and in the Division of Adolescent and Young Adult Medicine in the School of Medicine. After 30 years providing interprofessional primary care for vulnerable adolescents and young adults, her goal as director of the Family Nurse Practitioner Program is to prepare FNPs to provide culturally responsive, team-based primary care to underserved populations, drawing on the unique personal and professional backgrounds, skills, and interests of all team members to support patients in achieving their best outcomes. Next on the line, we have David Margolius. Dr. Margolius is the Chief Resident of Quality Improvement and Patient Safety in the Department of Medicine. As part of this role, he mentors interns and residents in primary care redesign projects. He's also authored several publications and spoken at conferences on the topics of primary care redesign and team-based care. A pretty formidable co-chief. And then last but certainly not least, we have Nwando Olayiwola. Can you repeat your name back now? I said okay. Dr. Nwando Olayiwola is the Associate Director of the Center for Excellence in Primary Care in the Department of Family and Community Medicine. Her role is to support the center in achieving strategic objectives around primary care transformation and systems redesign regionally, nationally, and internationally. Prior to this, Dr. Olayiwola served as the Chief Medical Officer of the largest federally qualified health center system in Connecticut, Community Health Center, Inc. Her work led to this Community Health Center, Inc., CHCI, being one of the first organizations in the United States to receive both the NCQA Level 3 PCMH and Joint Commission PCMH recognitions. Again, no small feat. So, as you all can tell, we have a very large and very accomplished and very knowledgeable panel. While this is not a debate, I expect you guys to agree. It is going to be moderated somewhat like a debate because we do have only a limited amount of time. So to start with, I'm going to go down the line and ask each of you a question related to your expertise and content area, and then we're going to open it up for anyone in the audience to ask questions of any of the panel members. So, starting with Dr. Gibbs. Dr. Gibbs, you host students from UCSF and across the country at the San Francisco Free Health Clinic. Are there ways that you have found to be able to teach primary care transformation in the clinical setting in real time? And I feel like as students, we often feel like we're more getting in the way of things rather than helping things. So how do you feel like the students are actually able to contribute to those efforts?
I think from the get-go, we've been doing it about, at the Free Clinic, almost 21 years, and then we were 3 years in private practice where we, again, had UCSF students and students from other medical schools. It's a sub-I. We came to that decision early. It's a sub-internship in outpatient medicine. So the students work elbow to elbow with R1s and R2s from UCSF and CPMC. And we don't distinguish between the two. So one, they're seeing somebody with a lot more expertise. I mean, that's sort of an R2 up there, the end of your R1 level is really the height of being able to do a snappy presentation. And the presentation, of course, to the attending represents that person's ability to collect information, organize it appropriately, and come up with an assessment plan and follow-up. The students like that. So we give them responsibility. And then they're responsible for seeing that it gets carried out. The labs are drawn, that the tests are ordered, and that kind of thing. So I think that, first of all, give them responsibility, too, because there's no money exchanging hands. And that's a luxury that we have, and I'll admit that. We're very fortunate to have enough funding to be able to continue with the free clinic for people with no health insurance, which is still an awful lot of people. And I think that creates a relationship between the patient and the clinician that's wonderful. There's trust there immediately because there's nothing involved except how can I help you with this problem. Nobody is more optimistic and impressionable than medical students, I think. And in those years, you just see it across the board, and you saw it up here, the ideas they have, what they want to do, the charitable thinking, wanting to give. It gets beat out of them a little bit in residency, and hopefully they'll come back into that, or maybe residency. So I think the environment we create there is how we, and of course we're family doctors, so we always look at the whole patient in terms of what we call healthcare maintenance, in addition to the presenting problem.
Excellent, thank you. And I think we will be hearing a little bit more about how we can maybe transform residency education. So Dr. Hammer, you are now in charge of integrated primary care for a very large safety net healthcare system. And yet you are still involved in our residency program and in quality improvement work that's happening by the residents. And so what are some of the primary care transformations that are going on in the San Francisco Health Network that you're particularly excited about, and how can students and residents be involved in those transformations?
Great. So my approach to transformation in primary care in San Francisco Health Network primary care comes from my background in quality improvement, and I always look at things and I'm trying to engage my team and the team in all of our clinics to look at things through the prism of the triple aim. So really to think about where we're trying to get to. So our vision for primary care, which is to create a sustainable model for patient family-centered care in all of our health centers. And to do that by improving the health of the population we serve, by ensuring an optimal experience for each patient who comes to see us, and by making cost-effective, appropriate use of scarce healthcare resources. So that's the triple aim. And then some people call it quadruple aim, but I actually think of the triple aim, and then the foundation that we have to build that on is a sustained and engaged primary care workforce. And so I was going to mention something we're doing in each of those areas. I think I'll probably run out of my time. But most of our approach is based in a team-based care model. So really developing the role of each person on the team. Just as we as physicians didn't go to medical school so that we could spend time filling out durable medical equipment forms, or for that matter, really teaching patients exactly how to take their medicines. Medical assistants also didn't become medical assistants so that they could spend most of their lives taking vitals. They actually wanted to be taking care of patients and helping a team take care of patients. And so we're really looking at how to expand the role of everybody on the team, starting with the most highly paid professionals on our team, which are the nurses and pharmacists, in addition to the providers, I should say. So going from providers to the other members of the teams, nurses and pharmacists, and really looking to see how we can train them, how we can empower them, and how we can teach patients how to engage with them so that they can work at the top of their license. So that's one of the big things we're doing. We've also developed and are starting to implement a behavioral health integration model throughout all of our clinics, which hits on a lot of those parts of the triple aim and improves the health of patients. It certainly improves the provider and staff satisfaction to have behavioral health people on our team. And then as far as patient experience, we're doing a lot in that area, really teaching each person who works in our clinics to put the patient first, to say yes to the patient, whatever you're asked. Patient presents for care, you don't think you have any appointments, figure out a way to say yes, to provide something to add value for that patient that day. So that's one of the, and then also around patient engagement, developing patient advisory boards and the role of the patient advisor to really help us with this transformation work, and really to team up with our quality improvement programs, with clinic management, so that we always are aware of the experience of the patient in the work.
That's amazing. I'm going to give you one more minute on your time to answer the second part of the question.
So that's a big challenge. So coming from an academic health center and now working with an amalgamation of academic health centers and 10 community-based health centers, this is a huge challenge, is how do we align our priorities, so our priorities around the AAA and the patient in front of us, with our very strong alliance and interest in training the next generation of healthcare professionals. So how do we do that? And I have lots of answers that I can't answer in 1 minute, but it's certainly a struggle. I think there's a way that we can really expand on already a mutually beneficial relationship between UCSF, all the schools, and our primary care health centers. I think we could do a lot more, but I think we have to figure out how to build an infrastructure in the clinics to support the training, the education of residents and students. And we don't have that infrastructure except at the academic health centers right now, but I'd love to see us work together.
Thank you. So Maria, you worked on a terrific primary care transformation project this summer. Can you tell us a little bit about how, sort of following up on what Dr. Hammer was saying, how you were able to integrate yourself into the clinic and do the quality improvement work that you did this summer?
Yeah, absolutely. So it's actually really wonderful going after Dr. Hammer, because a lot of things that she mentioned in terms of trying to expand how different members of the team are working on that team to achieve the goals was really the goal of this summer project. So as part of the Bridges Curriculum Ambassador Project, very quickly on what it was. We're working at Maximala Health Center, which is part of the DPH clinic, primary care clinic group, and so working on trying to increase mammography screening there, with specifically working with African American women and exploring that disparity there in terms of why their rates are much lower, especially at this clinic, and interviewing patients, interviewing healthcare team members, and trying to figure out what the issues are and how we can address those. And so part of this was, the goal was to create a some kind of tool for that medical assistants specifically to use in terms of empowering them with more information, more education on how to have those conversations and dialogues with the patients, and then in turn empowering those patients with more information. And for me as a student, it was really amazing for me to actually even learn about what a primary care team looks like. I think in medical school sometimes we don't get that kind of exposure, and so I was really pleased to really understand what a role of a medical assistant and a nurse on that team can be, and how we can work with that as as people who are interested in primary care, and for us that are student doctors interested in primary care, how we can just include that already in our learning from the beginning. And then really expanding on looking at the systems, even going to one of the Public Health primary care QI meetings. Coming in as a student, I really thought of primary care as like, oh, that community clinic that's working in a community kind of individually, and it wasn't really till I kind of immersed myself in this quality improvement project to see how, as Dr. Hammer mentioned, that it's really a whole effort of the entire education, all these clinics working together, having similar aims, and having similar projects and how they're sharing resources and what they're doing. And so as part of this project, I also got to work with different clinics working together on also mammography and sharing, this is what we're doing for mammography here, what are you doing at your clinic? And even later this month, I'll be giving a similar training that I gave at Maxine Hall at the Chinatown Public Health Center. So knowing that primary care isn't necessarily just one community clinic and a few primary care doctors working together and teams working together, but it's the medical assistant, the RN, everything at individual clinic level, and then also various clinics working together.
That's great, that's amazing. And after that experience and seeing how primary care works, are you still interested in the career?
Still interested in primary care. If anything, it expanded when you see how dynamic a primary care provider can be.
Excellent, good answer. Dr. Shaver, you work and teach at Kaiser, which is a very well-organized and highly effective system. And so my question for you is sort of two-part. How does, are there any lessons that you learned at Kaiser in terms of best practices to replicate or challenges to overcome in terms of transforming primary care? And now that it's also an educational institution, how do you plan to bring that into the residency program?
Yeah, both. You have to turn it on. You have to turn it on there. It is now on. Okay, very good. So I will, I'll address your first part of the question, which is best practices observed at Kaiser, and I'll dovetail a little bit off of what Dr. Hammer was discussing about empowering her team, all of the members of her team, to work to the top of their licensure. That's one thing that Kaiser's an integrated model has been working on for a very long time, and one of the short examples of that is that we do have pharmacists as care managers to do some of our routine chronic disease management work, including medications being adjusted under protocol and routine ordering of labs, and much of the patient contact is done over telephone visits for our hypertensives, our diabetics, our asthma patients. And this is not a new concept, but one of the things that I have observed looking at the research that Kaiser has done around these programs is that not just that they are and can be effective for patient quality care, and many studies have already shown that, for example, pharmacist-driven diabetic care can improve proxy measures, your A1C, blood pressure, etc. But when we are evaluating whether these are effective or not, we need to be specific and also realistic about the goals and the timeline that we're looking at. There was a recent study where Kaiser looked at the cost analysis using an economic modeling of whether this pharmacist-driven diabetic care management system would be cost-effective. And not surprisingly, their conclusion was, yes, it probably will be very cost-effective, but it's going to take about 4 to 5 years before that cost benefit can be seen without ambiguity. So when you're thinking about, future primary care leaders, when you go and you advocate for change in your organization and your leadership, I think it's important to remind the stakeholders involved that the assessment of whatever change you're trying to make should be realistic. If you try to assess it too soon, it could be disappointing or even damaging. You might let go of a good idea too soon. The second part of your question, how are we wanting to integrate these best practices and the Kaiser model of care into our residency program? Well, actually, I'm partnering with some colleagues at the UCSF residency and other area residencies to discuss a curriculum about basically primary care transformation, primary care delivery at the residency level. And one of the things that we are trying to keep in mind is that it's not good enough to just be within a highly functional system if nobody is pointing out what makes that system highly functional. There has to be a more overt curricular component to it, even involving just some didactic discussions of what are we doing and why are we doing it and what are we looking at. And that's part of what we're trying to create in this collaborative working group, as I discussed. One example of what we did recently, just with our first residency class that just started in June, during their orientation, was a didactic discussion and unit about the concept of the care team, which is very important in primary care transformation and patient-centered medical home concepts. We started with a short didactic about the concept of the care team as modeled in patient-centered medical home, and also derived from the building blocks and highly functional primary care practices. Thank you, Drs. Grumbach and Bodenheimer. We set the stage with that, and then we had our residents go shadow different members of the care team. An hour each, more or less, with our medical assistant, our clinical pharmacist, health educator, our receptionist, our LVN, and we structured their shadowing experience with some reflection questions that asked them to specifically evaluate what did they observe around the care team roles and responsibilities and team culture and function that we had just discussed, and what challenges did they still observe. And then we came back and we had a very animated discussion about where our rhetoric didn't quite meet our reality, because that's always going to be the case in whatever clinical area you practice in. And we found them not only invaluable in pointing out where our processes are working well, but also identifying some of our gaps. And I think that these are going to end up in some very beneficial practice improvement projects in the future driven by these residents.
Thank you. So Dr. Atkinson-McEvoy, you run a resident clinic and you also oversee medical student education, so you're involved both at the resident and the student level in education. And how have you been able to combine practice transformation with education, either at the resident level or the student level, and what have been some of your successes and challenges that maybe you could even impart both on the students and residents here, but on people who are newly running residency programs as well?
So UCSF as a health system has really started to tackle in earnest the transformation of primary care and our primary care delivery. And we look to places like the VA, San Francisco General Hospital, certainly Kaiser as well, who have been leaders in sort of their approach to patient care and doing sort of patient-centric, team-based care. We started this in our clinic with Dr. Emily Roth a little over a year ago, where we started really tackling having team-based care, and in our primary care residency specifically, delving a little bit deeper in how those things might work. And then we realized that this is actually something that's not only pertinent to primary care providers, but pertinent to all providers of healthcare, that the idea that patient-centered care, using healthcare outcomes to govern your approach to healthcare was an important thing for all our residents to learn about. So this year, we created a new curriculum that we are really in the initial phases of, which involves some didactics and also giving residents specific patient care outcome data, and how they're managing their patients, how our clinic is managing patients, and then challenging them to participate in a quality improvement initiative that's clinic-wide to improve care.
Excellent. It's very exciting. Thank you. And Erica Monasterio, you run the Family Nurse Practitioner Program. I had the privilege last year of working with one of your very talented nurse practitioner students at the Family Health Center. And how are you preparing your students to participate in primary care transformation? And what are ways that you envision, we talk a lot at UCSF about interprofessional collaboration. What are ways that you envision being able to really make that a reality?
So we have a couple of advantages in the family nurse practitioner program. First of all, we don't have to sell our students on primary care because they have chosen to train as primary care providers. So they're coming in the door and often have primary care experiences and ideas about transformation of primary care that they've developed from being in other roles in clinic environments. Our students, there's a Board of Registered Nursing requirement for a project planning course that our students take. And initially it started out sort of as a traditional inpatient CQI type of project. But through the efforts of both faculty and students, we've been able to really transform that into, for our primary care students, so advanced practice pediatrics, family, adult gerontology, nurse practitioner students, to really transform that into primary care transformation projects, where we're teaching the students not to go to a site and say, do I have an idea for you, but to go to a site and say, do you have an idea for me? So really starting with what the site's needs are, what their interests are. They get didactic support for, learning approaches, using PICO, using a plan, change, study, act paradigm, and they do a small test of change project. And we have to really emphasize the small test of change because they have 2 quarters to actually think about it, plan it, and implement it. So it needs to be small, but they get the experience of actually having a site identify an issue and then working with a team on the site and having a mentor at the site who's not their clinical mentor, but a mentor. It might be someone in administration, it might be another provider, it might be someone in a social worker, someone in a different role who has a vested interest in the project working to mentor them through this a small test of change project. So they're all having that experience, which is a great opportunity. Nursing is really rooted in a more holistic, well, let me not say more, but a holistic, patient-centered approach. So again, we don't have to undo that, or other approaches because they're coming from those perspectives. The project that I'm most excited about right now is a project that we are engaging with, starting with Hali when she was still more at the general. We've had about a third of our students do longitudinal placements in the Family Health Center with third-year residents as their preceptors. And for a number of years, it's been growing. It's a great experience for both our students and for the residents. But it's been a little bit one way. The residents are the preceptors for the FNP students, and the FNP students are there as learners. And what we're moving towards this year is a more interprofessional experience, where our students, instead of doing our project planning course, will do participate with the second-year residents in parts of the Aquila curriculum at the general. But there are pieces of project planning that will be built into that. One of our graduates who's been at the general for about 11 years now, she's an NP there and is faculty with us, is partnering with, so it's the 2 Naomis, Naomi Schoenfeld and Naomi Wardis, are working together to make this an experience that will work for both the residents and for the NP students, and then they will do a joint community project. And what we're really hoping is that this will give an opportunity for the NP students who often have experience in community-based work and a background outside of healthcare that can bring perspective and skills to this process to really be not only the learners but also sometimes the teachers. So a more rounded interprofessional experience.
That's great. That's very exciting. All right, Dr. Margolius. Before starting your residency, you worked with Tom Bodenheimer's team on primary care transformation. And so my question for you is how you have been able to integrate primary care transformation into your residency program, and in your new chief resident role, which is also a new role of being the quality improvement chief resident, how do you plan to pass some of that on to the medicine residents?
Sure. So I will say that before starting residency, like you said, I worked with Tom and Kevin in the Center for Excellence and Dave in the Center for Excellence in Primary Care. And I was just like Jacob Mirsky and Maisha and all these guys who were really excited about primary care transformation. And this was before Twitter was invented. Right? Maybe, I don't know.
2 years ago.
Which, yeah, whenever that was, yeah. And I was so excited. I read about the best practices, seen them, and even worked in some of the best primary care transform practices in the country and the world. And then I started internal medicine residency. And it's internal medicine, so it's not the whole patient, it's just the labs. And that's not
performing primary care as an improvement model, which kind of takes you step by step into, how do you first engage the leadership, as Dave was talking about first, to really make sure that there's a commitment and investment to making this culture change and this culture shift. And then using a number of other building blocks that are part of that, but how do you use data effectively, and when is it important? Can you start making major changes before you have data to do that and to support it and to sustain it? And keeping in mind what is that larger aim and kind of the holy grail of healthcare that we're all looking for, like Hali talked about. So that's what I see in the real world. But I think in terms of how students and residents can be active in transforming where they are in the real world, I think Dave hit on it when he talked about actually looking for places where you're going to train that support this kind of transformation and being active in that. I'm glad that Erica mentioned the family medicine resident and the MP student program, because it's actually been a really beautiful model for me to see the interdisciplinary collaboration that occurs in our clinic. And I've always been told that it's never be afraid to steal a good idea. And a lot of the great ideas we've had around our health coaching program and some of the work that we do in teaching have come from medical students who've actually taken the training or been part of it or have given us better ideas on what happened when they went out and used the skills that we gave them. So it's really great to be able to be humbled and to learn from those that you teach.
Excellent. And very timely. So now that we've heard from everyone on the panel, I'd like to open it up to the audience to ask questions either in general of the panelists or of one panelist in particular. And you can either just speak loudly and I'll repeat, or Beth has a microphone that she can bring to you.
It's not working.
Oh, never mind. Speak loudly.
Stand up and introduce yourselves and then project. Sorry. It starts working, I'll bring it.
Yes, in the back.
My name is Walid. I'm a second year medical student, and I'm very interested in primary care, and I've been very interested in seeing, some people spoke about the members of the team, of the healthcare team, the nurses, the pharmacists, family, doctors, and so forth. Can you give some concrete examples or stories of the discussions taking place between the nurses and the physicians and the pharmacists as to where they want to step up in the practice or step down, and how that is either enhanced or inhibited the overall function of the team?
Yeah.
Just one quick, turn it on. Thank you. One quick thing is that what we do, and we're small, so it's not maybe as easily done in a much larger setting, is we constantly change roles. So medical assistants have to go front and do the front desk. Front desk comes back and does medical assisting, and sort of everybody learns phlebotomy. And occasionally we'll have work details in the basement, and and for the doctors and the volunteers and the medical assistants, and so and they like that. That means nobody gets everybody. It means everyone is involved in clinical care of the patient. That they're personally invested in it. We have one person who's in charge of the front desk, and she does not come back and do medical assisting. But that's the only one in the clinic. Even our clinic manager has to bring patients back, do an intake, vital signs, and things like that. So that's one approach, and that may work in a smaller setting more than a bigger setting. But we have not had turnover for years in the clinic. People like coming to work because they feel invested in patient care, no matter what their title is or what their role is. So they may not be working right to the top of their degree. Neither am I. I remember being told mostly, work one level lower as a doctor than you've been trained to do, and that way you won't get in trouble. So I'm not doing heart surgery. I'm not putting in central lines in the clinic.
Dr. Shaver?
One of the major changes that we found very effective in our clinic was simply changing the frequency and the structure of our staff meetings. So I joined this program about 2 years ago. That was prior to the residency program actually existing. And when I joined, the staff meetings consisted of all of the providers getting together for an hour and a half once a month, and medical assistants were involved in about 30 minutes of that, and then the rest of it was just all provider time. Very quickly, we changed our module meetings. So instead of being a whole department, we have 4 modules per the department. Our module decided that with a residency program coming, we were going to be engaging in a lot of rapid change, a lot of rapid transformation, and we were going to need a lot more discussion about what the team structure, function, and roles were. So we made our meetings once a week, half an hour. Everyone has to stand, so nobody can talk too long. It is medical assistants, receptionist, our LVN. We get our pharmacists to come sometimes, and all the providers in the clinic. And we found that just by meeting more often and with everybody there the whole time, even just that small step built a little bit more trust between staff members, so that now there was a bit more comfort when a process change was introduced. There's a much wider group discussion about what does it look like from everyone's role perspective. There's a lot more engagement in collaborative discussion, solutions, and problem solving. And then we usually, what we found is that because we have a more frequent meeting, we can set a time frame of, okay, well, we have a change process we're going to engage in. Let's try it this way for 2 weeks, and then we're going to come back and we're going to report out. We're going to see how that happened. And we might change it from there. And so what we got involved in was very rapid PDSA cycles, plan, do, study, act. And we were able to do them over and over and over, and the process of that helped to build the team culture as well.
Maybe we can have, Dr. McEvoy answer, and then Dr. Norton.
I just want to share something that we do that's team-based, and we're not always entirely successful, but we're working on it, which is the team huddle, and we use them in our resident continuity clinic practices. So as described, residents are coming from a variety of different units, and maybe their heads aren't quite in the clinic at the moment they arrive. And so our huddle involves the front desk, our nursing staff, our clinic manager, the preceptors, and the residents, and it's really discussing what's going to happen that afternoon. And it is not always successful. There are definitely times where we haven't covered the right things, but it's an opportunity for us to take a break and get everybody's mindset into the afternoon and how we can best help the patients who are on our list. And I forgot to mention our social workers, who are a key part of our team as well. So that's one of the examples of bringing the team together and how it really changes care.
So before I realized that a lot of us were going to be excited to talk about our particular experience and answer to your question, I was going to actually just defer to Claire Horton, who's here, who's the medical director of the general medicine clinic at San Francisco General. And I think that clinic, because of the complexity of patients that they take care of, really has set the standard in terms of pharmacists and nurse roles and taking care of our most complicated patients. So an example, one that we have incorporated in a few of the clinics, is reducing readmissions for really complicated patients by engaging other members of the team to do the post-discharge follow-up and actual appointments. So a medical assistant or a health worker, preferably one who actually knows the patient, so who's from the patient's team, can call a patient within a day or two of discharge, check in to make sure they got their medicines, that everything's in place for them at home, and then to make sure that they know when their post-discharge appointment is. And what we found at Family Health Center is that a lot of those post-discharge activities are mostly around new medications and how to take their new medicines and how they fit with the medicines in their medicine cabinet at home, and blah, blah, blah. And so a pharmacist is the best person to do that. And one of our pharmacists has developed this whole model of the post-discharge appointment that a pharmacist does. Again, in close communication with the primary care provider, but believe me, she does it 10 times as well as I could ever do that appointment, and that's where her expertise is, so that's what she can spend the time on. So that's just one more example. I think there are a lot of how to really define roles and figure out who's the best person on the team to do it. Great question, thank you.
And Wally, just to add from our project, that was really the whole basis of the medical assistant program, was to interviewing a lot of medical assistants. It's not that they didn't want to have, our goal was to find out really reasons why women are declining their mammograms and explore ways that we could provide them with more information to empower them to make that decision. And it wasn't that interviewing medical assistants, which was our focus, and that's why I'm talking mainly about MAs, is that they may not have had that information, they may not have felt comfortable, so then the whole goal was to create a training for the medical assistants, providing them with information about radiation exposure, and it was more like they had this hesitancy because they didn't know all the details about that, so they kind of deferred to the provider to have that conversation. But providing that information, then they're a lot more comfortable having those conversations with the patients. So that's the way we had another team member on the team have those conversations instead of the provider.
Definitely lots of different ways to do team-based care, and also something that I think is very different from the way that primary care is traditionally practiced, and is also very different from the way teams are structured and look on inpatient rotations that many medical students probably have more exposure to. So certainly something that we need to increase exposure to throughout medical education. Other questions? Yes.
Hi, I'm Emily Roth. I'm a pediatrician at UC, and
You have to stand up and shout it out.
Sorry.
I got a new battery.
Emily Roth from UC. I'm a pediatrician. I work with Lee and a few other people back here. We were talking here about the Affordable Care Act and how exciting it is, and that there's a lot more funding for both practice and education, we're hoping. And I'd be interested in hearing if you've been thinking about that or how that might enhance the great programs that we're working on.
Did you guys, the question was about the Affordable Care Act and how money for education and transformation might impact the programs that our panelists are working on. Who wants to take the first crack at that?
I'm at a clinic, the Young Women's Clinic, which is a UCSF prenatal clinic for adolescents and young adults, and some adults, but mostly adolescents and young adults. That's co-located at the Women's Community Clinic. And what we have found is the most essential piece is training staff to be navigators. So really having not a follow-up appointment, not going to some other place, but right there, the same person who might have taken your blood pressure or sat with you and discussed your contraceptive options is also helping you navigate through that system, because it is a very challenging system. And we're having very good results because we have many patients who have healthcare coverage only because they're pregnant. So they have, they have CPS, P-Medi-Cal. And after they're not pregnant, for those who are undocumented, there are very few options. And for those who are documented, it's very challenging to figure out where they go next and what they qualify for, what the baby qualifies for, etc. So the navigator piece as a member of the team, and not importing necessarily somebody new, but training up the people who are there on the ground and know the clinic as it functions already.
And is that something that's funded through the Affordable Care Act, or is it something that the clinic has to use their funds
So
for?
Women's Community Clinic has some HRSA funding that included navigator training, but has actually come to the plate with unrestricted funds in order to make it happen.
Yes, Dr. Gibbs?
We obviously run a free clinic for people with no health insurance, and our volume has not fallen off, and so we're in a perfect position to ask why. We have a social worker at the clinic. At our expense, she agreed to be trained as a certified enrollment counselor for the Affordable Care Act, and not only because and then our attendings are instructed to ask, and the students and the other clinician is, why are you not yet involved in the Affordable Care Act? Or Medi-Cal, since the enrollment that it's going to close, but it's going to open again soon. And we're in a perfect position to see why. And what we found is for the patients we see, which is mostly a working population, but a population that earns very, very little money. They don't have an extra $10 in their pockets, let alone a $40 or $50 copay. And so the bronze plans, that they maybe could squeak out and afford, and then maybe they'll get their preventive care for free, blood pressure checks and cholesterol and birth control. But if they get a headache or a back sprain or, all the things that we mostly see people for, and then we try and do the preventive care around that once we've got them in the room, they can't afford it. So the Affordable Care Act, on that basis, on the ground level, we're huge supporters, and it's much, much better to have insurance than not. We're there to cover it. We are happiest stable when we can close the doors and walk away. We kind of figure that's going to be years from what we've seen yet. It needs to be tweaked. It's a good thing. We fully support it. A great start for a country like this that's embedded in private healthcare as it is. Great start. But it needs to be tweaked because there's a lot of people that's not going to reach it. It's still too expensive.
So yeah, I was going to just add that I think similar to what you just mentioned, that the emphasis on preventative care, that's the affordable care, has really been such a win for primary care in general in all the exchanges. But one thing I thought is not really from the practice end, from the patient end, but more from the practice end, is the emphasis on accountable care organizations and interprofessional team-based care in the ACA does give a lot of momentum to patient-centered medical home transformations. And we've seen, I think right now, close to 30 state Medicaid programs that are now providing more of a higher level of reimbursement for practices that have transformed to patient-centered medical homes. And so it's not necessarily much in all the states, but definitely recognizing the extra time it takes to coordinate care and to do some of the in-person care that's required to manage patients, particularly in the safety net. So I think that's a really big bonus, and we've seen a lot of states shifting towards this transformation, largely
and having more time, just using our resources. So.
One more question.
Well, it's not a question. I was going to make a comment. So I'm the president and CEO of a large medical group out in Walnut Creek, and we struggle with all these the same issues. And I was just thinking of some examples. You mentioned orthopedics. We had, for years trying to set up a family medicine-based sports medicine clinic. And every time we tried, of course, the orthopedics, very powerful out in our area, just stomped it into the ground. And not long ago, one came up to me and said, wait, where's that sports medicine clinic you guys were setting up? We're going to stop it in the ground. And of course, what had happened? Well, the way patients were being paid for the care of patients, right, went to a capitated model. So suddenly, because all these things that you're talking about with the CMA and all, it's all turf battles. It's all over. It's all over structure. I worked with a nurse practitioner for many years in my practice, and in fact, I've always said in general internal medicine, I wouldn't practice general internal medicine without a nurse practitioner. There was a team then that we had taken care of patients, and that goes back some 20 years. But very, very recently, as we developed the medical home, one of the issues for primary care physicians is, right, if you set up a structure where the physicians are still in a fee-for-service model, they're expected to see 24 patients a day, say, and you set up a medical home where the easiest cases are taken care of in the urgent care or by nurse practitioners or some other member of the team that can take care of it. What's happened to the physician then is, wait a minute, so I get not only 24 patients a day, but the most complex patients, and I have to still see 24 of them. So all these things are really have to do with transitions of the model. So what I would tell you is, if you want all those battles to go away, you just change the model, right? As soon as everybody in a practice is there to take care of a population of people, then everyone will then immediately start using people as an asset rather than seeing them as a competitor. That's the answer.
Thank you. Well, that was an excellent summary. But yes, Marianne, please.
One second, because I have the forum. Back to Dr. Miller's question about mentorship, something that came to mind later. Is also, I think about the reason I'm interested in primary care and the wonderful access I had to primary care physicians as my mentors, pretty much all of which are in this room right now. And that also makes a difference. And I think that accessibility of primary care physicians as mentors for medical students could make a huge difference. I think that's not always who we're seeing in the classrooms, we're seeing on the wards. And so that's important too, that we put that effort in to have primary care physicians as our mentors, easily accessible. And that all those physicians, which I never had an issue with, are very passionate about sharing their passion with us. And that's made a big difference from a student perspective.
So we've heard a lot from our excellent panel about both team-based care and involving students and residents in primary care transformation. And I'm struck by how they're kind of parallel processes of involving people in things that they may not necessarily traditionally be used to being involved in and may not necessarily feel totally comfortable being involved in and may not necessarily have great models to follow. But I think the same way that in group-based care we ask every member of the team to work to the highest level of their license, I think that we can also ask students and residents to work to their highest capacity and sort of taking advantage of the fact that students have a lot of optimism, we heard, a lot of energy, a lot of flexibility, a lot of ability to think outside the box because they're not yet enmeshed in the system. And so I found myself thinking, well, what do residents have to offer other than the ability to tell you where the closest bathroom is at any point? And I think that residents really do have a lot to offer in terms of having a fresh, critical eye to processes and really being well poised to not just talk the talk, but learn to walk the walk. And in order to do that, we need, I think, as our panelists pointed out, we need excellent mentorship, not just in primary care practice, but in primary care transformation. And everyone here in the room is involved in that, either as a mentor or as a mentee, and probably as both. And we also need systems that are able to change to incorporate primary care transformation and also to incorporate learners into those models so that, as David was pointing out, they can really see this process and transformation in action. And so I'm very excited to have heard from all of our panelists. Thank you so much also for your excellent questions and participation, and go out there and mentor and mentee and transform.
echo the thanks to our panelists and also to our fabulous facilitator. We're going to take a short break. I know some of you need to go off to other meetings, but probably not as inspirational. And when those of you who are going to stay for the afternoon, take 5 minutes, come back, and don't plunk yourself down too comfortably because we're going to do a little mixing and matching. So 5-minute break, and thanks to everyone who do need to leave for the day. We really appreciate your coming.
Hi, how are you? What's up?